and specifically with a focus on Japanese encephalitis. Okay, so we'll start now. So as you guys know, meningitis is a inflammatory disease of the meninges. It is essentially because of this inflammation, there exists irritation of the meninges. It causes nuchal rigidity. It can manifest as increased intracranial pressure, which thereby leads to nausea, vomiting, photophobia. So, but the underlying pathology is that because of either inflammation, which might be due to infection, which might be due to a drug, which might be due to any cause, it is causing the leptomeninges to be irritated. Remember, it is a medical emergency because these meninges are in direct contact with the brain, and whatever irritates the meninges irritates the brain and can lead to seizures, and especially if it is an infective process, it can result in the it can progress very fast, lead to infarction and other complications thereof. So the various other types which you should know is that one is an acute meningitis, one is a chronic meningitis. Chronic meningitis is arbitrarily defined as one which lasts for 4 weeks or more. Then we have got myelitis and rhomboencephalitis. Rhomboencephalitis is what we call as the brainstem encephalitis. This is a very serious conditions. Variants like bigger staph encephalitis and exist. They manifest with, and as you guys know, brainstem is what controls the whole body. So they have got features of respiratory abnormalities. These patients have a lot of hemodynamic instabilities. These patients have got blood pressure fluctuations. These have the cranial involvement, and they go into shock. They can go into a vasoplegic distributive shock. There can be myelitis or inflammation of the spinal cord, which will manifest upon what is the area involved. There can be weakness, so and depending on what area specifically, if it is involving the motor part, the sensory part, unilateral, bilateral, and depending upon that, the symptoms might occur. Going on. So what an encephalitis is? The International Encephalitis Consortium, it has given a very objective definition. So up till now, we were discussing about meningitis, spinal cord inflammation, and brainstem inflammation. Suppose this infection percolates and now causes infection of the brain, which is what is encephalitis. So this is defined as when there is an alteration of the mental state, that is a cortical involvement lasting for 1 day or more with no other alternative cause, and 2 or more of the following for a possible, and 3 or more for a probable diagnosis. So the patient should have fever, patient may have seizures, patient has focal neurological findings, patient has CSF pleocytosis, has got a MRI feature, the MRI which is suggestive of encephalitis, or an EEG which is suggestive of encephalitis. So as you can see, there are 3 clinical signs: fever, seizure, focal neurological deficits, and 3 lab signs. Your on the basis of lumbar puncture, on the basis of MRI, and on the basis of EEG. Abnormal brain function is what differentiates the encephalitis from meningitis. So when we talk about meningoencephalitis, it is essentially when the patient has a concomitant meningeal irritation and brain manifestations, so encephalitic manifestations. Then there are other varieties. So we are first of all focusing on the terminologies, because whenever we ask you these questions in the exam, there is always a confusion. So I'm focusing on these first. So going on, radiculitis. So going further from myelitis that we had discussed in the spinal cord, from the spinal cord appear the nerve roots. So if there is a nerve root inflammation, it is what is we call as radiculitis, and this manifests as a lancinating pain, weakness, dysesthesia, something like a pins and needles sensation, and obviously this can result in hyperreflexia. Because okay, then we go on to what is a meningoencephalitis or encephalomyelitis, depending upon where the infection starts. So if the CNS infection starts with the meninges and goes on to the brain, or the CNS infection starts with the brain and goes on to this thing, it will depend upon meningoencephalitis or encephalomyelitis. Then there is a condition called encephalomyelitis. This is essentially when the brain and the spinal cords are inflamed. This will be manifested by this is essentially chronic infections which occur mostly in the viral infections. Then we have got encephalopathy. Encephalopathy is essentially this is a term which is used to imply that there is a disruption in the brain function. So it is more of because functional manifestation, which can or cannot be cause of an infection. There can be various causes like toxin mediated hypoxia, ischemia, drugs, which can result in this kind of a abnormal brain function. So in India, there was a consensus guideline which was adopted, and they adopted a term because you can imagine each of these terms is very specific. So in the peripheries, sometimes it gets confusing for the healthcare worker to decide what is the terminology to be used. So a terminology called AES or acute encephalitis syndrome was devised. This is any child or any patient of any age which has got acute onset fever and change in mental status and or seizures. So having seizures is not this. Basically, it is a febrile alteration of a sensorium, which is acute encephalitis. Fine. Mostly, it is considered as infective cause in the peripheral India, and the Sharma et al. Gives a very good consensus treatment for AES, acute encephalitis syndrome, which we will be discussing here on forth. But before we go on there, let us talk about how the infection reaches the brain. So brain, up and unless there is a hole or a burr hole in the skull or the cranium, the infection cannot reach there. So it reaches that cannot reach by a direct route, but it reaches by indirect route. So it can reach by colonization of the respiratory GI or the lower genitourinary tract, whereby the organisms like meningococcus they colonize by using organelles like fimbriae or pili. From there on forth, they invade the bloodstream. Then they have got certain mechanisms like the polysaccharide capsules which prevent them from being phagocytosed and which protect them in the bloodstream. And then they gradually enter into the subarachnoid space by penetrating the blood-brain barrier, and once they are in the CSF, because the human immunity is impaired in there, they multiply rapidly, and depending upon where they are seeded, they can have features of meningitis first, going on to meningoencephalitis or encephalomyelitis, depending upon what kind of organs are involved. So as we had discussed, the organisms they enter the CSF. After that, they release the various uh, cytokines like TNF alpha and IL-1. These are the ones which also are responsible for the body's mechanisms to, like, the patient starts having fever at this point. This causes the inflammation of the blood vessels and the vasa vasorum, and this results in infarcts, which is the occlusion of blood vessels. It also causes a recruitment of the leukocytes into the brain, and they release further mediators, causing more endothelial leakage. There is a concomitant blood-brain barrier injury, which results in vasogenic brain edema. And as you guys remember from the Monroe-Kelly doctrine, brain plus blood plus CSF is constant. If there is more interstitial edema, there is more swelling of the brain. It results in compromise in the circulation, and it will also. So all these things happen in the case of meningitis, and these manifest as increased ICP, increased intracranial pressure. Suppose we did a brain biopsy at this time, we will find features of necrosis in the cortical and the subcortical structures, and there might be features of demyelination of the white matter. So what are the features? What are the predisposing features? You guys know, depending upon, in case you guys want to ask me something, please post the questions in the question tab. Going on. So these, just bear with me. Yeah. So going on, the predisposing factors for meningoencephalitis are that the patient is exposed to a person who is having this kind of infection, who has this kind of a disease process, especially when the disease process is aerosol mediated or spread by aerosol precautions if they are not taken, then there can be a decent infection. For example, if, as you guys know, the contiguous areas of the brains are the ears, ear canals. So if there is any otitis, it can penetrate, it can cause an inflammation of the structures in the vicinity like lemurs, and it can again go to the brain. So all those things can happen by the infection of the contiguous structures. Then if there is a recent travel to endemic areas, penetrating head trauma, yes, that can cause a direct infection into the brain. If the normally closed orifices start leaking, for example, there is a CSF autoria or CSF rhinorrhea. In all these conditions, what happens is that there is a leak of the CSF, and the organism, the Encephalococcus, they get access to the brain parenchyma, and obviously then there can be features of staphylococcal meningitis and abscesses in the brain. Then obviously cochlear implants, if they get infected, and at any anatomical defects like dermal sinuses, or if we make a defect like a VP shunt is there and the patient has a peritonitis, there will be an ascending infection of the brain. So all those things, if occurred, those things predispose to having a meningoencephalitis like phenomena. So essentially it is break in the normal defense mechanisms which the God has given us. So these are kind of, the patient has got VP shunt which is exteriorizing. So what are the host factors? One we have discussed is that there is a defect in the God given basically protective phenomena like break in the mucosa, break in the normally closed orifices, which cause the infection to penetrate into the brain. Then it can often occur that the body's defense is not adequate. The infection is entering through the indirect routes. So this was when we talked about the direct entry of the infection to the brain. Then, as we discussed earlier, some organisms have got their protective phenomena like polysaccharide capsules, and they can enter into the bloodstream and invade or overcome the host immune system. Sometimes the host immune system itself is incapable. For example, if there's an opsonizing antibody, in those conditions, strep pneumoniae, H flus can be more. If there is asplenia, then those organisms with the caps with capsule like Neisseria meningitis, strep pneumonia, those kind of organisms can occur. Complement mediated, those organisms that are destroyed by complement mediated pathways like Neisseria meningitis will obviously flourish in a complement deficiency. Similarly, in those patients with a B-cell immune-mediated disorder like HIV, especially, they can have some opportunistic infections like Cryptococcus neoformans, Listeria monocytogenes. Then, if you have got a cardiac infection, in those cases as well, especially when there is a LV on the side, and it's on the side of the left ventricle, then there can be an ascending infection to the brain. Baseless fracture by the similar means of break in the barrier of contiguous structures will allow the access of the organisms into the brain. So when a patient comes to us, you have to look for clues in the child. When you take a history, the first thing you guys say is, I am presenting a case of this many-year-old child with history of this thing. So the first thing you guys introduce a case is, you talk about the patient, talk about the patient's age. Patient's age is very important in deciding what are the possible organisms he could have had. Because, for example, in a less than 3-month-old child, organisms like group Streptococcus, gram-negative bacilli are very common. In bigger kids, strep pneumonia, Neisseria meningitis are more common. This is also important because this is why the pneumococcus vaccine is given at these age groups. As we grow older, the kids present to us more with Neisseria meningitis, strep pneumonia infections, and in even older kids, the predominant causes are Neisseria meningitis. So just a cephalosporin appropriate dose might be enough. While in smaller kids, to cover streptococcus, I might need to add amikacin or aminoglycoside on top of it. So this is also important in deciding what antibiotic is required to cover them. Fine. So the when we talk about a disease like Neisseria meningitis, the most common cause site of entry is nasopharynx. For strep pneumoniae, it can be nasopharynx or a contiguous um, spread. Listeria monocytogenes, these are sometimes responsible for uh, early sepsis or early sepsis issued meningitis. There are various complement or rather innate immunity related deficiencies which predispose organisms, as we have discussed earlier. Okay, so we will not discuss this a lot. This is a little important because especially when we have got some extraneous devices in the body like a BP shunt or a prosthetic valve, then it is important to keep staphylococcus as a differential, and then the drugs like vancomycin and they are important in covering those organisms. Okay, then we have talked about bacteria. Now we'll talk about the viruses. There are various viruses which are neurotrophic. These include enteroviruses like polio, echo, coxsackie. There's obviously HSV2, the various kind of arboviruses. Some respiratory viruses, they start with a respiratory infection and gradually the patient has starts becoming encephalopathic, and because of the secondary involvement of the brain. The influenza viruses we have seen in the recent COVID pandemic also, there have been reported cases of pediatric COVID encephalitis. Fine. So these are those organisms where when you will do an LP, you will not find cells. So this is what we call as an aseptic meningitis. Some bacteria like just slow growing like Borrelia, those can also sometimes lead to aseptic meningitis. Mycobacterium tuberculosis normally has got very typical manifestations and will have increased proteins, but may have a lower cell count. Fungi, Cryptococcus, Coccidioides, Histoplasma, Blastomyces, all these are common in T-cell mediated disorders like HIV and can have. Then obviously we have discussed about things like acanthamoeba, tinea, which you guys must have read in micro. Those kind of organisms can cause meningitis. But remember, as we had discussed, this is an inflammation of the meninges. Infection is just one cause of the inflammation. There can be other causes of the inflammation, though these causes are rare. For example, in a case of a leukemia, when we start giving chemotherapeutic drugs into the CSF, or if you are administering something into this system like azathioprine or pyridium, those kind of things can irritate, can cause meningitis as they enter or in the CSF or introduced. Then malignancies, we guys always know that they can seed the meninges and cause similar symptoms. There are various autoimmune phenomena like SLE, which can have features of meningitis. So what are the, this is a very busy slide, but this was only introduced so that you can know what is the context in India. In India, the Japanese encephalitis is very common. There were outbreaks in 2006 in eastern UP, in Lucknow, in Delhi. Herpes virus and encephalitis is common. Dengue is common. There is a Chundipura encephalitis, which was there, which was in 2003, 2000, as recently as 2007 was there. And there have been outbreaks of Nipah viruses in Siliguri, in West Bengal, basically in the northeast India. And other causes like cerebral malaria, tubercular meningitis, rickettsial, those are also important. So this was essentially the things which will give you clues on the history of, about the etiology. Now we go on to how do you take a history of this patient. We know that this is essentially an inflammation of the brain and which results in concomitant ICP. So it will have features of fever, headache, vomiting, seizures, as the meningitis will cause encephalitis. So when there is an inflammation of the cortex, we will have altered behavior, cognition, personality changes, depending upon which part of the cortex is involved, whether it's a frontal, temporoparietal, or occipital, and then that uh, symptoms will start manifesting. Obviously, like especially when there are viral meningoencephalitis, there is often a prodrome, which will be a flu-like illness like fever, cough, cold, coryza, and loose stools. And after maybe day 4 or 5, depending upon what is the incubation period of the virus, the patient will start having the symptoms. Other thing which is important to ask is where does the child reside? Whether there are mosquitoes in the vicinity, whether there is a local outbreak of the AES in the vicinity. Obviously, we have to ask about any animal contact like dog bite, rabies, any insect bite, any arthropod bite basically. There is there. We know there are other alternate causes like drug and toxin exposure which can cause this. Any history of recent travel and history of trauma can precipitate. These patients have got seizures. So the seizure, we need to ask whether they have got any personal or family history, because this particular disease process can exacerbate the underlying illness and precipitate new semiology of seizures. Recent immunization will result in will obviously we have to then consider that whether this is a AEFI. If the patient has got recurrent episodes of altered sensorium, then it is not often a AES. We have to consider things like urea cycle defects and other differentials like Munchausen by proxy. Other cause of encephalopathy like hepatic, renal, dyslipidemia. If you guys have attended the class of electrolytes, things like hyponatremia, all those things can manifest in that. So, but remember that patients may not often have the classical symptoms of fever, stiff neck, headache, photophobia. So we have to look for other concomitant signs like alteration of sensorium as well. So symptoms of encephalitis are very important. Things like alteration of personality, especially when there is a frontal lobe involvement, any motor or sensory deficit. Sometimes these organisms, they harbor only in a specific area, and it's at which time only that specific area's manifestations will be there. So there might be some focal neurological abnormality which might happen in the child. Seizures are only there in up to 1/3 of the patients. Fine. It is important to ask for immunization history as we have discussed. Drug allergies, especially anaphylactic reactions, are important. So less than 1 year. So what we have discussed, if an infant comes to you, you will ask for features of fever, hypothermia, lethargy, distress, jaundice, features of increased ICP like vomiting, somnolence, loose stools, then features of ICP like bulging, fontanelle, and sutural diastasis. You guys know that we have to assess at the petrosquamous suture also to see if there is a sutural diastasis. In the older children, they'll be able to vocalize more. They'll be able to indicate for subtle signs like photophobia, which an infant may not be able to give you. They will, and in those patients, you will might be able to localize depending upon what is the focal neurological deficit that the child has. So that is what we talk about in the history. There can be vesicular rashes of herpes. There can be features of the hand, foot, mouth disease. There can be a rash of Rocky Mountain spotty fever also. This kind of a rash, you remember, is can be seen in a measles also, in a measles-form eruptions. Then we go on to the specific neurological examination. First is the assessment of the higher mental functions and the GCS. You will find that if the GCS is low, it means that the substantial part of the cortex is involved, and this also carries a prognostic significance, because a low GCS at arrival would mean that the patient requires ventilative support, and obviously a substantial part of the brain is already involved, so the chances of recovery might not be as good as if the child has come in an early part of the disease process. Then features of increased ICPs, you can have false localizing signs of ICPs like third, fourth, and sixth nerve involvement. They can papilledema, but it is less common in meningitis, because remember, papilledema normally occurs because it's a chronic process. It happens late. But if the rate of development of ICP is very acute, by the Hayes hypothesis, it will cause and basically the obstruction of the vasa Verbodoms, and it will cause an increase in the inflammation. It will cause the papilledema features to occur. Then we talk about the features of meningeal irritation. The most common signs we know are the Kernick sign and the Brudzinski sign. The Kernick sign is that you guys, I hope you guys are aware. Let me just see if I'm able to play this. So as you can see, the child is not able to extend the leg completely. Fine. So this was the Kernick sign, that we place the child supine, we flex the hip and knee, and we cannot do it. And at 90 degrees we try to flex, as we try to make it straight, we're not able to. This is because the meninges get stretched. Then there can be a Brudzinski sign. This is the similar sign which we do especially when at the neck. So as you, if I hope this video plays. So as you guys can see, as the child is flexing the neck, it causes, because of the nuchal involvement, it will cause the flexion of the lower extremities. Fine. So these are the other signs which you guys know what we call as meningismus. So nuchal rigidity, Kernick sign, Brudzinski sign. These all gives us the clinical features of meningismus. Fine. Then, so after doing the history examination, the next thing which you do is doing the blood test. So obviously we need to see features of inflammation. So we do the total leukocyte count and the differential leukocyte count. We see the aerobic blood cultures. We see for other alternative etiologies like sodium, glucose, urea, nitrogen, creatinine. We see for LFT, because those all can cause encephalopathy, especially if the patient has a particular rash. Then we need to see for PTA, PDT. We need to see for features of inflammation like CRP, procalcitonin, and other causes like malaria. So RDT, that is the rapid diagnostic test we need to do. Then there are some diagnostic clues which we can have. Suppose you've got a patient who comes to you with meningismus or meningitis with thrombocytopenia, then causes like rickettsia, HSV, causes like dengue, those kind of features are more common. On the contrary, if the patient has eosinophilia, features, then conditions like toxocara, trichinella are more common. Patients can have rickettsia, tuberculosis. Those often have SIADH more commonly associated with them. Then, as you guys know, the test of choice for these patients is a lumbar puncture. Depending upon features of increased ICP there or not, in the lumbar puncture, when we do, we always see for the cytology, we see whether there are polymorphonuclear leukocytosis. I hope you guys remember your physiology days when we used to use the improved newborn chambers to see how how to do a cell count. The similar skill set will be required as you go on to your sub-specializations, because this skill set is extremely important. So you are expected to know how to see through the improved Novas chambers and where to appreciate what is the cell count. Then we need to see the biochemistry. So what is the sugar and protein strength? We need to do a gram stain. Then Zeal and Nielsen staining, again it will be depending upon what percentage of H2SO4 you're using. Whether you're suspecting nocardia, you're suspecting tuberculosis, so there'll be different strength of H2SO4 that will be used. Then we'll ask for blood, obviously we'll ask for bacterial culture. We'll do a PCR for HSV 1 and 2. We'll assess for IgM antibodies for Japanese encephalitis and dengue as required. Remember that when we are doing a sugar in biochemistry, there should be a concomitant blood sugar that has to be done, because it is the ratio of the sugar consumption in the CSF which gives us an idea as to how much is the bacterial insult in the brain. Any questions up till now? Any questions? Okay, so I will continue then. Okay, so again, by knowing the total leukocyte count and the biochemistry, we can get a rough idea. So if a patient has got low glucose, high protein, high total leukocyte count, we know that this patient has a bacterial meningitis. On the other hand, if the patient has a normal glucose or a normal protein count with a slightly less or rather normal total leukocyte count, then we know it is more likely a viral meningitis, as that's what we were discussing, aseptic meningitis. Those kind of organisms can be there. Obviously, if the patient has some in tuberculosis, you would expect a protein content to be very high, but cell count will be low. Fine. Then what we have discussed already, that the viral picture will be of a normal CSF glucose, less protein, and negative gram stain. They may or may not have an RBCs. This is more pathognomic of some conditions like HSV or but again, having or not having RBCs does not really confirm or exclude a disease process. Then there are other etiologies like Epstein-Barr virus. Suppose you have got a patient who has come to you with infectious mononucleosis with the Alice in Wonderland syndrome. So in this particular case, the patient has got metamorphopsia, and and this patient went to do and has got aseptic meningitis. So in this particular thing, you can do a PCR in the CSF. Similarly, the small kids, the neonates which come to us, they have a torch route of infection. So CMV, HSV, toxoplasma, rubella, herpes, these kind of infections which are inherited from the mother to the child. So in those cases, we need to do a paired samples of the child's and the blood samples in the blood. In this CSF also, we may need to send a PCR to see how it is, whether it is there or not. Then the other, we had discussed about the what do you call it? We had discussed about the gram stain in these cases. So in the gram stain, what needs to be seen is that so what you can see here. So we have got gram positive diplococci. So these are things like Streptococcus pneumoniae. There can be a gram negative diplococci. So things like Neisseria meningitis, that those are common. Here also you have got some they are basically pleomorphic gram negative coccobacilli. So things like Haemophilus influenzae B are more common. Then gram positive cocci. These will suggest groupish streptococcus. And these kinds of gram positive rods and coccobacilli, these suggest Listeria monocytogenes. Fine. So on the basis of that, so we have done up till now, we have taken a history. We know what predisposed this kid. We know what organisms as per age which can occur. We have taken a history. We have done an examination. We have done the lab tests. We have done the CSF tests. We have done the grams. Now we ask for cultures. Obviously, we can't get a culture in a viral because it's not easy to see until we can get plaque assays. We can get antibodies, but getting a plaque culture is more difficult. But yes, we can get bacterial cultures as required. For virus and other organisms, sometimes there are rapid diagnostic tests which are available, which can, and nowadays there are things like multipov. So these are essentially assays which will give you or like rapid fire PCRs. So they can give you a bunch of organisms within 6 to 8 hours. They can just screen, they can do PCRs for what all organisms are there, and they can give a very quick diagnosis within few hours, and on the basis of that you can start the treatment. But obviously these are not available everywhere in the across the world. Then now that we have done all this, there is a lot of imaging. Imaging, you should remember, a normal CT scan does not, so suppose a patient comes to you with a normal CT, but remember this patient can have features of increased ICP, because in only a limited percentage you will have features of impending herniation in there. Fine. So patient can always have a non-pressure hydrocephalus, and patient can still pone. So remember, a normal CT does not exclude ICP surges. And so whenever we are doing an LP, we always screen where this patient has papilledema. We always screen where this patient has increased ICP features, and we always screen if the patient has any alteration. So if the patient has trauma, patient has got a shunt, patient has hydrocephalus, patient has papilledema, patient has false localizing signs, then before doing an LP, it is advisable to do a CSF imaging, because we don't want this to do an LP, the patient herniates, or rather to be very specific, has got a tentorial herniation, herniation of the cerebellar tonsils. So as you know, these are just in brief about the various kinds of MRI findings which can happen. and the MRI findings, they vary somewhat as per the viral etiology. For example, HSV, there will be a temporal lobe localization. In flavivirus or eastern equine virus, there are lesions in the thalamus, basal ganglia, midbrain. In the enterovirus, in the hyperintense T2 and the flare lesions in the midbrain, pons and medulla are there. In the RSV, like the respiratory viruses like influenza, and influenza, adeno, RSV, you will have features in the thalamus, basal ganglia. Fine. Then things like Chandipuram, in those it can be normal. Okay, so these give you an idea about what are the various, they give you a surrogate idea about what kind of etiology it is. So how do we treat? First is we see for the features of increased ICP. So first is if the patient's GCS is low, we intubate the child. Especially if the patient has got impaired reflexes, has got abnormal respiratory pattern, increased ICP or desatting, then obviously you need to intubate. Then we look for the ventilation abnormality. If the patient is having desaturation, you have to intubate. Then these patients, remember, need to, because they have increased ICP, that will counteract the body's blood pressure and not allow the perfusion to take place. So you need to have a cerebral perfusion pressure directed treatment, or in other words, MAP minus ICP should be appropriate. These values are age appropriate. So we need to maintain a reasonable MAP for the patient as per age to make sure that the blood supply to the brain is adequate. And how do we do that? We either do it by fluid resuscitations, but remember these patients have SIADH, so we may not be able to give a lot of fluids. Then we might need to start some inodrops if the patient has vasoplegia, so vasopressors might be needed. Then we need to obviously take the samples and treat accordingly. If the patient has shock, we need to follow the surviving sepsis guidelines and treat the patient by giving fluid resuscitations, monitoring lactate, taking blood cultures, and thereafter. Obviously, we need to have a strict neuromonitoring. So monitoring the GCS, monitoring the DTRs, monitoring the planters, monitoring features, monitoring the pupils, all these things help. If the patient has ICP or patient has seizures, we have to give phenytoin. Then obviously we are managing. So we manage, management is the emergency. Then you can do the investigations. Empirical treatment as per the guidelines of India is that we have to start a broad spectrum antibiotic like cephalosporin. We give acyclovir in all suspected viral encephalitis. Artesunate, we can start and stop early if the RMAT or peripheral smear is negative. Then other supportive, so the brain is obviously involved. So we need to give we need to protect the brain by maintaining the homeostasis. So we maintain euglycemia, we maintain normothermia, we maintain basic adequate level of hydration. We treat ICP by head and elevation, head in the midline. We treat seizures. We maintain sodium. If you guys remember the class on sodium, we need, and as the sodium is responsible for the blood osmolarity, we need to maintain osmolarity between 145 to 155. So that, sorry, the sodium between 145 to 155, so that the concomitant osmolarity above 290 can make sure that the fluid is not taken away from the blood vessels into the interstices and contributing to the cerebral edema. So it should stay in the blood vessels. That is why we need to increase the ICP, and by increasing the sodium, the blood will have enough osmolarity to try to pull out the fluid which might have leached out, thereby decreasing the ICP. So hypertonic saline is normally given as boluses or infusion as needed in this particular patients. Then once, and steroids, there are some studies which are there when they're normally given in conditions like ADEM, that is acute disseminated encephalomyelitis. Then once the infection has occurred, whatever insult has happened, then the next step is physiotherapy, posture. Then whatever insult has happened. So now it has reached a chronic stage. Now the next step is physiotherapy, posture change. So now with whatever is left, when the acute part is over, then what are the defects that are left? Those need to be treated. So if there are contractures and whatever are there, those, if there are bed sores that are formed, those need to be treated as required. Okay, so just a little bit about the Japanese encephalitis, because it's very common in India. As you guys know, it is humans are incidental or dead end hosts, and it is spread by Culex vishnui, specifically Culex meningitis. They are being classified in India as lab confirmed, especially when we have got a suspect case which has now got the antibodies against it, or probable when there is a geographical distribution and the clinical symptomatology is of that of Japanese encephalitis. Its incubation period is 5 to 15 days. The symptoms are usually non-specific, and there is a prodrome initially like fever, diarrhea, and followed by features of headache, ICP, vomiting will start happening. They will be then have features of cortical involvement like encephalopathy, so mental status changes, neurological deficits occur. Patient then start having seizures. In the MRI, as you can see, you will see thalamic lesions which are there. In the EEG, these patients have got theta or delta comma and burst suppression is there. In the diagnostic testing, there is a JEJ, so Japanese encephalitis virus specific immunoglobulin is detected in the CSF or serum. This you have to treat supportively because unfortunately there is no specific drug against it. What is more important is prevention, because this has got a very high mortality rate and long-term sequelae occur 30 to 50%. So you can imagine, at least for any patient that comes to us, one third will die and half to one third will have long-term sequelae. So it is important to prevent. So currently in India, a cell culture derived live attenuated vaccine is available, which needs to be administered subcutaneously in areas where there is geographical predisposition. Fine. So now we have discussed about the acute meningoencephalitis. Just the last few bits about the chronic meningoencephalitis. This is when it is lasting for more than 4 weeks. These have got, so this is obviously a concern because we need to keep a differential about non-infectious causes like leukemia, lymphoma also in this. Infectious causes, things like parasitic, cryptococcus, coccidioidomycosis are very common. They can be detected on MRI, and the biggest causes like Mycobacterium, Borrelia, Brucella, HIV, they are the ones which lead to these kind of infections. Then fungal infections like Cryptococcus, Histoplasma are important. Parasitic like Taenia, Schistosoma, Acanthamoeba can cause. Non-infectious causes like SLE, Behçet's, all VPH disease, they are all common. And as we have discussed, intrathecal agents as we insert during chemo, IV immunoglobulins, they can all cause aseptic meningitis. So what do we do in this case? We do a CSF examination like we had discussed earlier, protein, glucose, staining, we can do some latest agglutination, we can do cultures, we can do various serological tests, and then we can do imaging studies like CT, MRI. If we have got a specific test like 1,3-periodic glucan is there for Candida, then Aspergillus, we have got Galactomanans, we have got the Montus for the Montu skin test for pox. Then we can do other things. If like for pox, there can be other signs. There can be lymphadenopathy, so we can take a lymph node biopsy. Fine. And then there can be specific tests. Like for Japanese encephalitis, we can do IgM antibody. For enterovirus, we can detect by RT-PCR. For dengue, again, we can do an IgM antibody. Fine. So they are basically mostly it's antibody mediated tests which are there in the viral etiology. Okay. Thank you. Are there any questions that anybody wants to ask, please? If not, then we will conclude the session. I see no questions, so I think we will conclude. Thank you.